All right, ladies and gentlemen, thank you so much for joining us for the J.R. Williams Senior Class of 31 Endowed Lecture Series, in which the title today is The Brave New World of Assisted Dying, Enlightened or Dystopian, with Dr. Madeline Lee speaking to us from the University of Toronto in Canada. Before we do a formal introduction, I'd like to tell you a little bit about Dr. Williams. The Williams Endowed Lecture Fund was initiated in the fall of 2013, supporting lectures on spirituality and health at Tulane University School of Medicine, focusing on the art of creating a compassionate and trusting relationship between patient and doctor. So obviously, this is also spread to other lectures in medical ethics and medical humanities. The series honors the legacy of J. Richard Williams, Sr., who was a Tulane University graduate and very well-known and well-loved internist and oncologist in Selma, Alabama. Dr. Williams loved medicine and was the kind of doctor who would do anything for his patient. Now you have to remember, an oncologist back in the 30s, 40s, 50s, unfortunately had to do a lot of palliative care because the overmastering of oncologic disease was quite common at that time. So he paid a lot of interest on the impact of spirituality on health, particularly on the positive impact of spirituality on the well-being and continued health of those who had suffered the loss of a loved one.
Okay, I found this on the web. For the series honors the legacy of J. Richard Williams Sr., who has a Tulane.
Not sure why Siri just did that. In the meantime, I also would be remiss if I did not note the co-sponsors of this talk, which is the Master of Science degree program in bioethics and medical humanities. We are on the web at tulane.edu/bioethics. Actually, if you just Google Tulane and bioethics, you'll come straight to our program. And we were also on YouTube at Tulane Bioethics. We have two tracks, a bioethics track, which is sort of a classical track in teaching, research, and service, whether it's a hospital ethics committee, institutional review board, and then in terms of teaching in healthcare settings and conducting normative empirical research in healthcare ethics. The medical humanities track focuses on teaching or research in aspects of narrative, reflective writing, fine arts, and history, as it applies to healthcare. We have a 1 or 2 year MS program, which is flexible as a faculty development option for mid-career professionals, so that it can actually stretch out into 4 to 5 years. We also have an integrated dual degree MS program where one is here at Tulane University, and then the coursework is taken during elective time slots in the first and second years. We also have 12-hour certificates in clinical ethics, research ethics, and medical humanities. I will leave the QR code for just a moment and remind you of the web link, which is at tulane.edu/bioethics. Dr. Stephen Hansen, who will be moderating our session today, is the Director of Graduate Studies. His email address is here. And Sofie Offengenden, PhD, is our Program Manager and also instructor in the program. Now for our introduction. Dr. Madeline Lee is an Associate Professor in the Department of Psychiatry, University Health Network, and a clinician scientist in the Department of Psychological Oncology and Palliative Care, Princess Margaret Hospital, the University of Toronto in Canada. In 2017, she authored with others, Medical Assistance in Dying, Implementing a Hospital-Based Program in Canada. in the New England Journal of Medicine. In this article, Dr. Lee asserted that the legal responsibility to implement MAID, or medical assistance in dying, required creating an institutional framework for patient assessment and provision of service, as well as a plan for educating staff about engaging in conversations with patients. In addition to her clinical practice in cancer psychiatry, her research interests are in depression, quality of life, psychological oncology, patient experience, and conducts collaborative research in the areas of psychoneuroimmunology and genetics. She is the developer of and physician lead of the Distress Assessment and Response Tool, or DART, program at PMH, and the Psychological Oncology clinical lead for South Central LHIN. She completed her MD PhD at the Ontario Cancer Institute, followed by a residency and fellowship in psychiatric oncology at the University of Toronto. Please let's give a warm welcome to Dr. Madeline Lee, who will speak on the brave new world of assisted dying, enlightened or dystopian. And before we start, reminder, CME credit is available for this lecture. Please, in the chat, please just list your name, your email, and the type of CME credit that you're requesting. Thank you so much.
Okay, so I'm going to share screen. Where did my...
There you are.
Okay, great. So thank you so much for that introduction, which was much more comprehensive than the couple of lines that I'd sent you. So thank you for doing that. And thank you for this invitation. I'm really honored to be giving this endowed lecture, this Williams endowed lecture. I hope I can do, I think the topic does this justice, does the intent of the endowed lecture justice, and I hope I'm able to live up to that. So I also heard at the beginning when I put up this title slide initially, a mention of we're already in dystopia in the United States, and so it's really not a question. And I think what you'll hear from my talk today is that there's a lot of nuance in this topic of assisted dying. I do call it a brave new world. And it's actually not enlightened or dystopian, or I should say we have the answer to that. And the answer is yes, it is enlightened or dystopian. It is both. And I think that the same is true of any divisive topic. It will depend on your perspective, right? And so the brave new world, is this enlightened or dystopian? It depends on whether you're reading Huxley or Shakespeare. In Shakespeare, this was a very enlightened thing, not so much in Huxley's version of it. So we'll see what you think at the end. I look forward to the discussion. I will start with my disclosures. And so as you've heard, I developed the MAID program at UHN. I also have a couple of funded research grants to study the evolution of the desire for assisted dying and its impact on patients and family. And I have been paid as an expert witness for our government in a couple of legal challenges to our law. And I, as you'll hear at the end, am also involved in a project where we're trying to develop a standardized training curriculum for healthcare providers in Canada. And I'm the scientific lead on that project and the chair of the module where we are trying to teach people to assess capacity and vulnerability. Because my main interest around MAID is not should we do it or shouldn't we do it. I think there's nuance and balance and a middle position in everything that we do. I'm not opposing or advocating. I've always come to this work from the perspective of it is now legal in Canada. We are doing it. And so if we're going to have to do it, then we have to do it safely in a way that respects the rights of patients who can access it, respects healthcare providers who want to exercise conscientious objection and not be involved, and also protects vulnerable patients who maybe shouldn't be accessing it. And that's what I'm hoping to show you today. Okay, there is a ton of terminology around assisted dying. There's several variants of this. I'm just going to emphasize two because my slides will speak to them. Euthanasia is the concept that this is a clinician administered end of life at the patient's request, usually by administering a intravenous substance. Physician assisted dying, or PAD, and euthanasia tends to be legal where it's legal in Europe. Physician assisted dying, or PAD, is what it's generally been called in the United States and other countries, where instead of the clinician administering a lethal substance, the clinician prescribes a medication that the patient then takes by themselves. We can talk about whether there's an ethical or practical or clinical difference between that. This term MAID, which I will use as a shorthand throughout my talk, medical assistance in dying, was really sort of coined in Canada, and it includes both. So both are legal in Canada. Either we provide it to patients or patients can do it themselves. I want to remind people, as we're talking about assisted dying, that that's actually a very small proportion of the end-of-life pie. Most people at the end of life will die naturally, either through good palliative care, we hope, or through palliative sedation. And it's a very small proportion, different in different countries, but less than 5% generally, where at the end of life, people choose assisted dying. So we have to think about this being an exception to the norm and why some people will want this and whether it's right for them. I also want to emphasize the cultural context of where it's legal. And I think generally we have found that the drivers of assisted dying, this has never come from medicine. It was never doctors saying, we want to do this. And there's we can discuss this, the whole issue around, does it conflict with the Hippocratic Oath and things like that. But really the drivers it has come from the populace, and in Canada from legal challenges to the laws, driven by case law. And I think the drivers are generally that there's the aging of the population, increased secularization in the population, this push since the 60s towards increased personal control and autonomy, consumerism, and patient empowerment. And you take especially the last three of those together, and what you're really describing is a Western population, which is why when you look at the geography of assisted dying, it's largely a phenomenon of Western population. So available in 7 countries, 11 American states, not all of America, and then expanding now to Australia and Germany, New Zealand, Portugal, in various forms. I won't go through the details of this slide, but just to let you know, the bulk of the world actually does not permit assisted dying. So it's not only a rare phenomenon where it's legal, it's rare globally. And what do we know about how it is applied globally? I think it's always interesting to look at jurisdictional differences. And so what I've done in this table, I'm not sure if you can see my pointer, but is list the countries where, the major countries where it's legal, and divided, whether they allow euthanasia or physician-assisted dying, and then the controversial areas. And the controversial areas of your assisted dying law are whether you require a terminal illness or not, and whether you're going to allow this for children, for mental illness, or as an advanced request in the context of dementia. And in general, countries that have a more liberal law, where they don't require a terminal illness, do allow it for the more controversial areas. Whereas countries that have a more restrictive law, where it is limited to the last 6 months of life or something, and that's what you have in the States, don't allow it for these more what are called expanded indications. If you want to use the word indication, if you think of this as a medical intervention. Canada has been in this unique position where other countries have at least known what they wanted to do from the outset and established that. Canada's laws have evolved, and although both euthanasia and PAD were allowed to begin with, initially we had this poorly defined entity called a reasonably foreseeable natural death, which was removed subsequently. And we are now considering legislation for the remaining 3. Mental illness, made for mental illness, will be allowed in Canada we think it will be as of March 2024. What difference does the variations in assisted dying law make, I think it affects how often you see MAID happening, and whether this is a good thing or not kind of depends on where you sit on the continuum of support for assisted dying. But generally, in countries with more permissive laws, in the Benelux countries, Belgium, Netherlands, Luxembourg, the rates of MAID or assisted dying have increased over time. Whereas in countries with more restrictive laws, they've not, where you've maintained a 6-month prognosis, for example. In red is what Canada has done, where we started with what people thought was a more restrictive law, and then it's been a little exponential what's happened in Canada. And again, that the data are what they are, whether that's a good or bad thing will depend. We can certainly talk about that. Let me try a little bit to explain how we got here in Canada. As I said, for us, it came through legal challenges of 2 patients, and I've described them there, with conditions that were not terminal illness conditions, AML and an elderly woman with osteoarthritis and chronic pain, got Canada to recognize, to acknowledge that this was a violation of their Charter of Rights and Freedoms, that we were violating their right to life, because if we didn't allow them assisted suicide, somebody with ALS might get to the point where they couldn't take their own life, and therefore had to request MAID or do something about ending their lives while they were still able to, which was costing them life. And that was the reason why that was felt to be a violation of the Charter of Rights and Freedom. And the Section 15 was about right to equal benefit, that everybody has the right to this protection of life. And the feeling at that time was that if we put in the right safeguards, we'll be able to protect vulnerable people. And so actually our Supreme Court ruling in February of 2016 was very broad. And it said just that it was unconstitutional to prohibit assisted dying if you're competent, you consent, and you have a grievous and irremediable medical condition that causes enduring suffering that is intolerable to the individual. The Supreme Court's ruling was very autonomy-based. It's about what the individual is willing to tolerate. It did not specify anything about being in an end-of-life state, having a terminal condition. But the federal government introduced Bill C-14 over a year later in 2016. And these are the Canadian eligibility criteria, where you have to have substantive safeguards to be eligible for MAID. And that includes having Canadian healthcare, because we did not want death tourism happening in Canada. You had to be an adult, you had to be capable, you had to be making a voluntary request, you had to be providing informed consent, including being told of the alternatives. And then you had to have this entity called a grievous and irremediable condition that was defined as having an incurable condition, being in an advanced state of irreversible decline in your abilities, having enduring physical or psychological suffering, and this really undefined construct where your natural death has become reasonably foreseeable without defining how long that is. Each of those criteria clinically have their challenges in interpretation, and I won't go over that too much today because I'm trying to keep this a little bit higher level. But each of those criteria have had challenges in interpretation, particularly that last one. When does your natural death become reasonably foreseeable? Because it actually was not required in the original Supreme Court decision. And then there are a bunch of practical safeguards where you have to provide a request in writing and have 2 independent witnesses. 2 doctors have to assess you against the eligibility criteria. You had to wait 10 days. You had to be asked just beforehand, are you sure you want this? You had the right to withdraw it at any time. What subsequently happened, though, was there were challenges to the grievous and irremediable condition criteria, because taken together, even though there wasn't a defined how long this reasonably foreseeable natural death is, taken together, this sounds like an end-of-life patient. So 2 further legal challenges came forward. And what the government did was strike the reasonably foreseeable death requirement, although all they did was change it from being an eligibility criterion to being a safeguard. So you still do need to have a reasonably foreseeable natural death. But what happened in this new legislation, C7, Several changes were made. They certainly made it easier. You only need one witness, a healthcare provider can witness. But what they did was create two separate pathways to access assisted dying. So if you have a reasonably foreseeable natural death, and if you don't. So now in Canada, if your death is reasonably foreseeable, you have terminal cancer, you no longer need to wait even the 10 days. It's eased the pathway. You no longer need to be capable at the final moment. If you don't have a reasonably foreseeable natural death, so it's now been open to people with chronic illness, you have to wait 90 days. You do need to be capable at the last moment. And then they put a couple of or three extra safeguards in where your assessors determining if you meet eligibility criteria have to be informed by expertise in your medical condition. You have to be offered consultation for the alternatives to MAID. And the assessor has to feel that the person has appropriately considered those alternatives. Let me just emphasize in the law that this is still very autonomy based. You have to be offered consultation. You're not required to accept it. But what this track does is give the assessor some voice. In the original C14, the law was very focused on your suffering cannot be relieved by any means acceptable to the patient. And now the clinician has some voice as to whether this is a reasonable thing or not. So that's the state of our law. And here's what's happened with our law since it was over the last 7 years. We've had over 31,000 MAID deaths. More now, I think we are well over 45,000. This was just to the end of December 2021. The average age is elderly, 76. There's been a slight trend towards more men than women receiving it, although it's generally about half. Very clearly, the most common medical condition underlying the MAID request is cancer, 65%. There has been a consistent and gradual increase in the numbers of people accessing MAID over time, about 34% per year. In Canada, generally 4% of patients are found ineligible last year. 81% of requests actually result in MAID, and those numbers differ from the United States. And we can again speculate about why. I think what's important is to recognize that 80% of patients who received MAID also received palliative care. And interestingly to me, there's actually been no data captured in Canada yet. They will on psychological supports. Although that is part of palliative care, but dedicated psychosocial support is not actually captured as a data point. And I think what's interesting is that Canada's initial MAID experience, and most of that data is predominated by eligibility under C14 when there was a reasonably foreseeable natural death required. Our MAID metrics are very much in line with what you see globally. And so what I've put up here is at least Oregon's Death with Dignity Act after 20 years. And it's very similar where they see a slight preponderance of men. It's generally an older population. It's higher, but generally because of cancer. These tend to be white patients, largely 96% are white, highly educated, so more than high school education, if you add these up to in over 80% at least of the cases. And the main reason driving the MAID request is loss of autonomy, inability to participate in activities they previously enjoyed. And that's my point around why Canada has not been collecting psychosocial metrics, so psychosocial care. If you contrast that to the reasons for MAID requests in Canada, the point I want to make is I think the public at large view MAID as something that is given to somebody who is in unbearable physical pain at the end of life. And that's actually not the prototype. It's not what we see. We have good palliative care. Over 80% of people receive it. No one's physically suffering in Canada as they're dying. The reason people want MAID is mostly psychosocial, mostly psychological. It's because they can't engage in meaningful activities. Inadequate pain control is 50%, but that matches with loss of dignity. It's predominantly a psychosocial phenomenon. And my experience has been it's predominantly about a desire for control. In some ways, I would say, do we need MAID? No. But is it a choice that people want? And is medicine providing, and therefore medicine is providing it? Doesn't medicine need to provide it? That's another thing we can talk about, but it is something a minority of patients want because of psychological suffering. I might detour a bit just to describe, therefore, how I got here. Maybe I'll share that with you. It is psychological suffering that's driving this desire for MAID. And I would have to say, I did not come into this work as an advocate. I, in fact, thought we have good palliative care, we have good psychosocial care. I'm a cancer psychiatrist, most cases are cancer. What I do for my vocation is I help patients with their psychological suffering at the end of life. And these are people with psychological suffering at end of life. And they're saying, no, I don't want your help, but don't give me your counseling, your medications, end my life. And I would say I struggled with that. I felt it's one, professionally invalidating, but I had to learn it's not about me. It's about what they wanted. And what I've learned over time is to become comfortable with the minority of people who want this. And I will describe some cases at the end that shifted my thinking around that, and that led me to realize that actually for some people, for the right people, this is the right intervention. So what people would those be? There's the phrase, what doesn't kill you makes you stronger. And if you've read Mortality by Christopher Hitchens, who died of cancer, he has a great quote, in the brute physical world, the one encompassed by medicine, there are all too many things that could kill you, don't kill you, and then leave you considerably weaker. And he prefaced it by, I no longer use this phrase. I think that's the rationale for MAID for some cases. And this is Dr. Lowe, who was the chief of infectious disease at my hospital, actually one of the leaders who got us through the SARS pandemic before we had COVID. And he had a brainstem tumor that was costing him his ability to hold his eyes open, he would eventually lose his ability to breathe, certainly starting to compromise his speech. This was at a time before MAID was legal. And this is Dr. Lowe telling you why he thinks it should be legal.
Palliative care is a major role and a valuable role, but they can't take away the symptoms that I'm going to have. They can help make it a little bit better, but I'm still going to suffer from loss of strength, loss of ability to either eat or swallow, breathe properly. I mean, these are things that palliative care is going to hopefully make it a little easier to face, but they're not going to take it away. I'm not afraid of dying. I could make that decision tomorrow. So I just don't want to see a long, protracted out process where I'm unable to carry out my normal bodily functions and talk with my family and enjoy the last few days of my life. The fear is that that is not going to happen.
And so it didn't happen for him because MAID was not legal then, although he was an advocate for it. But this was the first case that made me sit back and think, could I have helped Dr. Lowe in a different way? He was not in pain. There were no palliative care symptoms. He was not vulnerable. He was not marginalized. There wasn't a lack of finances. This is a physician. And I realized that much of the suffering he was talking about wasn't even existential suffering in the sense of my life has no meaning, I'm depressed, or I'm afraid to die. I watched that and thought, this is psychological suffering about anticipating the course of his disease that I would have limited ability to help with, even though I'm the head of psychosocial oncology at Princess Margaret. So I want to talk a little bit about initial MAID conversations and how important it is to recognize our role as healthcare providers in having these conversations, and that there is a spectrum of conscientious objection. I think we always make a mistake when we think of MAID as being a very black and white thing. There's a range that you can go from, I really object, and I'm ethically against this, and I cannot even participate in a discussion to the other end where I can assess and provide MAID to a patient. But in the middle is a range where you're actually okay to have a discussion with a patient and maybe refer about, is this the right decision for you? And then maybe refer them to somebody else if it is the right decision for them. Or to actually, while they're going through their MAID process, you stay involved. You don't refer them to somebody else. You help them manage their symptoms and their values as they're going through the MAID process, not as their MAID provider, but as their clinician, helping them deal with the alternatives, deal with the suffering and engage with the alternatives to MAID. So I think it's important to recognize that there is a spectrum. And it's so important for us as healthcare providers to think about that spectrum, because I think there's a reflex that a MAID request is an automatic referral, and it's not. It should open a conversation, not a conduit, right? It is your first opportunity to talk to a patient about their symptoms and their goals of care. And I think what's missing in the Canadian law, and I hope can be built into our curriculum, but would apply to any MAID case you might see, is that clinicians should be trained to have a therapeutic conversation with the patient to help them understand the nature of their suffering and acceptable means of relief, right? And the idea is to help them make their own fully informed decisions. And it's not just, why do you want MAID? I want it because I'm afraid of how I'm going to die, or I don't like my current quality of life. You can look at the facts of what they're giving you as the reason for their suffering, but I think it's important not to take that at face value. Many patients don't know what underlies the nature of their suffering, and it actually needs a bit of a therapeutic conversation to help them unpack that. So here's an example. Fred is a patient I had recently, an 84-year-old man, another highly successful person, a lawyer, well supported by his wife. His children were doctors, large group of friends. He did have a severe history of depression, which had been stable until he was diagnosed with a head and neck cancer. He did have an obsessional, disproportionate preoccupation with symptoms. He had a dry mouth, and he had very low tolerance for any physical suffering because he was a Holocaust survivor, and there was trauma from that. And so any suffering triggered, he didn't have PTSD, but any suffering triggered memories, and he couldn't tolerate physical suffering. This did get better with counseling and antidepressants, and he was okay until he developed a local recurrence of his cancer with metastases to the lung. He was started on immunotherapy. It was just his first cycle of treatment. Both the family and the medical team were hopeful. The immunotherapy has changed the landscape of cancer. People can survive for years if you're a responder. But Fred was very focused on, I need to prepare to die. And he was perseveratively focused on dying, and his family was concerned. He's like doing his will, he's giving away possessions. He's just focused on the fact that he will die. He has no hope that the immunotherapy would work. And after the one immunotherapy treatment he had, there was rapid growth on his PET scan, which was either hyperprogression of his tumor, or there was a chance it was pseudoprogression, just a reaction of the tumor to the immunotherapy, and the oncologist wasn't sure. But Fred immediately wanted to stop immunotherapy and given the MAID the same day, because now we're post Bill C7. You don't have 10 days to wait anymore. You can ask for it and get it today. His mouth discomfort became 10 times worse, and he was saying, I'm suffering, my family's suffering, I want MAID today, I don't want any more immunotherapy. And actually, he met all eligibility criteria. He was not by me, but he was assessed by another assessor and found to be capable of making his decision, because actually in Canada, you're allowed to refuse treatment. The treatment would not have cured him, no matter what happened. It was still an incurable disease. His oncologist said we should wait and know for sure, is this progression or pseudoprogression? And his family were in support of his decision to have MAID, but this was very sudden, and they hadn't shifted from hope to acceptance. And what I did was I helped him explore the nature of his suffering, the urgency of his wish to die. I explored this concept of self-perceived burden that we talk about in psychosocial oncology, where it is disproportionate self-perceived burden, that you think you're a burden to your family, but if you check in with your family, his family wanted every last moment they could have with him. They didn't perceive his presence as a burden. not enough to make him incapable, his self-perceived burden, but it was a psychological factor that he had to come to recognize. I explored the urgency that underlay his desire for MAID, and it was this fear of loss of control with cancer, very much tied to him saying this: Hitler took away my control over life and death. MAID gives me back control. He wanted to choose how he died. It was a choice, rather than really not capably being able to recognize that his suffering might be transient, it might get better. So I adopted a shared decision-making approach with him and said, it's not that you're not eligible, you absolutely are. But my clinical recommendation is that you don't yet. This should not be a rushed decision. And he waited so long as his MAID process was in process, and he wouldn't be denied the option. And the final outcome was that with that conversation, he was better able to tolerate his mouth discomfort. Confirmation that this was hyperprogression. We got palliative care involved collaboratively, and they provided aggressive symptom management. He knew that if he had unbearable suffering, palliative sedation could be arranged probably more quickly than MAID. The palliative care team also played a role in providing support to his wife and family. And then what was really important for him was the ongoing involvement of palliative care and his clinical team in helping him decide when to go ahead with MAID. Because, as I said, there's this spectrum. Rather than just saying I can't be involved at all, there's an important clinical role to helping a patient figure out when is the right time. He was actually able to accept caregiving, adapt to his loss of function. He wound up in a hospice. And even at the end, he was saying to me, because I kept, every time I met with him, I said, what's your quality of life now? Is it still worth being around? And he was in bed, immobilized. And he said, but I can still look out my, so weak, he couldn't get out of bed. But I can still look out my window and see a blue jay. And that will bring me joy today. And so it's not time yet. And it actually took, first the conversation was about not yet. And then my conversation became, listen, if you really want this, you need to know, like he was waiting until he was physically suffering so unbearably that he would want to go ahead with MAID. And I had to explain to him that may not happen. You're actually, the way you are now is the worst you're going to get, and you'll just start sleeping more and eventually drift away. He didn't really understand what his natural death could look like in that sense. I had to explain that to him. When he started developing fluctuating terminal delirium, I said, if you still want MAID, it's now or never. And he was a capable man. He then said, then it's now, because absolutely he wanted to take control back from Hitler. And so he did receive MAID unambivalently with full family support. It's a case I'm trying to illustrate the nuance in how to walk a patient through this process. And it really shouldn't be a black and white. You want it, you meet eligibility, go ahead, you can have it. And it shouldn't be, because there is this whole other slippery slope that's happening. And I'm sure you've all heard about it in the news. There have always been concerns that MAID would be imposed on the vulnerable or the marginalized. And there's lots of research evidence that that has not happened in the Benelux countries over the years it's been legal. We're not imposing it on people in that sense. But we are seeing this other slippery slope of expanding indications, where I think what we're seeing is the medicalization of all forms of life suffering. We're treating suffering with a medical intervention now, which is death. And I think we see this in tired of life cases that are legal in Belgium. They're called completed life cases in the Netherlands that are considering legislation, where people don't really have any particular illness, but they're tired of it, tend to be elderly patients who are tired of being alive and just want to die. In Canada, these cases actually are happening. We call them frailty cases. These are because now you don't need a terminal illness. You don't get to be 90 years old without having some qualifying medical condition like diabetes or some condition that can be considered incurable and will qualify you, but really you're tired of life. And that's because Canada has chosen to interpret a reasonably foreseeable natural death as a reasonably predictable natural death, something that's more proximal, more distal, right? You can have a very long description of time prognosis and still qualify as having a reasonably foreseeable natural death. I think you have seen all these, this page shows numerous news headlines about people in Canada now accessing MAID for inappropriate reasons, like poverty. Very related, not end of life elderly patients, but young people whose desire for MAID is driven more by psychosocial circumstance. And again, we can talk about that. But because Canada has opened MAID to chronic illness, it will open MAID to psychiatric illness. And that is a whole other complication around MAID. There is this concept of psychiatric futility. It's an emerging concept in psychiatry where you take a palliative approach to people with severe and persistent mental illness. The palliative approach is really where you stop trying to force institutionalization and ECT and medications with side effects, but to accept their symptoms and align with their goals of care, because we otherwise are doing iatrogenic harm. But the intent is to switch the focus to quality of life. And the challenge is, if you're going to say that psychiatric futility exists, and there's papers that support that, how can you deny these people MAID? The problem is, how do you know when psychiatric futility exists? When have you reached that? And in many ways, I think the people in favor of this define it the way Justice Potter defined pornography, right? I may not be able to define it, but I know it when I see it. It's your clinical judgment that is supposed to come in. I think the challenge with that approach is it depends on whether you're on the board or you're the principal of a 6th grade art class. Everybody's personal definition of what is psychiatric futility will be different. And I think that lack of consistency represents a safety concern. Having said that, MAID for mental disorders is coming to Canada. What can we learn from the Benelux countries? We know the rates have been increasing. We know the population shifts from being what the cases I've described to you, largely affluent, highly educated people used to being in control of their lives. It shifts from that to being more marginalized people with low socioeconomic status. And interestingly, there's a 2-to-1 sex ratio of women over men who receive psychiatric MAID. And the concerns are around the things you would expect, right? How are we defining that this disease is incurable? How are we going to assess capacity? What do we do about the structural vulnerability that's driving the request? I think the biggest debate around that is on this issue of, at a societal level, how are we balancing autonomy versus paternalism? Is there a muddy middle position? Just looking at the time, I think I'm not going to go over this slide in a lot of detail, only to say that, I think when there are fundamental disagreements, they are based on values, different from non-fundamental disagreements, which are based on facts, and you can resolve them by presenting facts. When you have fundamental disagreements, like autonomy versus paternalism, the only thing you can do is dispassionately present both sides. And that's what this slide is meant to represent, that around those criteria of uncertainty around incurability, the value of hope, the role of treatment refusal, there are arguments on all sides. And there is a middle ground that says, in a minority of cases, it might be appropriate to provide psychiatric MAID. I think what we as a society need to determine is how we feel about autonomy versus paternalism. And I would argue we're not talking about paternalism, because that's actually not a defensible position. Nobody wants to be paternalistic. We're talking about autonomy versus protection. And it's a false dichotomy to say we're going to create a regimen that is 100% autonomous or 100% protective. I think what we need to recognize as a society is that there's going to be this unavoidable trade-off, that if you take a very autonomy-focused approach to allowing assisted dying, some people will receive MAID who many people think shouldn't. And if you take a more protectionist approach, some people will be forced to continue lives that they don't want. And so which end of those mistakes is better? Which mistakes are you willing to make more of is the question. And so this brings me to my last section, which is really to focus on the difference between the right to access MAID and the appropriateness of a patient for a patient. And that's a perspective I'm trying to build into this MAID curriculum that I mentioned. One of the issues in Canada was that no healthcare provider ever learned to do this in medical school or nursing school. It was never taught. And then from one day to the next, it was a medical intervention we were expected to be able to provide without any training. And so we actually need to train the entire medical workforce, the existing medical workforce, and how to do this in a safer and more appropriate way. So that's the goal of this curriculum, to provide standardized education that will hopefully provide more consistency in MAID practice across the country. There's multiple modules associated with this, and I'd be happy to share the content of these modules as they come through, because I think they will be relevant to other jurisdictions. There's 7 modules that focus on just the basic ethics and the description of the background and how we got here. There's a module on clinical conversations, right? What do you do with an initial request, and what kind of conversation would you have, whether you are going to be involved with MAID or not? And then modules on assessing and providing MAID. This is the module I chair on how do you assess vulnerability and capacity in a patient. And then a module, of course, on MAID and mental illness, logistically complex cases. And embedded throughout is actually content, on resilience and reflection for the healthcare provider. I did position a vulnerability model in the module that I chair that really asks clinicians to think about their own biases and take them out of their assessment, to think about the patient's vulnerabilities and how do you protect those patients. And in the end, how do you go from having an eligible patient and engaging in a shared decision-making model so that it's not just eligible, go ahead. And then there's an evaluative component to the curriculum, because I think we always should know what the impact of having the availability of a curriculum like this is on the healthcare system and on healthcare providers. So we have several questions tied to that evaluation. I just have one case I would like to end with, because I feel like in the last little while, I've given you a lot of my concerns around expanding MAID and how to do this work and how nuanced it is and how challenging it is. It can also be very simple. And I really do need to emphasize that this is the bulk of MAID. This is, for now, we'll see what happens when the indications expand in Canada, but this is 80% of the cases that we've had over the last 7 years. There's a misconception, as I said, that it's about unbearable physical suffering. It's existential suffering. I've learned that there's 2 kinds of patients who ask for MAID, basically those who are afraid of dying and those who aren't. And those who are afraid of dying with significant death anxiety or demoralization want it as a backup plan, but they don't go ahead with it. Still, having the option of MAID is powerfully therapeutic to them. Those who do get it tend to be accomplished, affluent, highly educated, high life satisfaction. They prioritize control. And actually, my clinical experience has been MAID is the only way to help these people often. For multiple reasons. They're often not open to psychological support. They are people like Dr. X. So I have one last video to show you. This was an 82-year-old woman, single, no children. She was a university philosophy professor who was teaching until a year before this video was made. And she actually was a nun. She'd spent many years in a convent and left to pursue her PhD at a time where there was upheaval in the church. She had advanced ovarian cancer. She was admitted to our palliative care unit with a short prognosis of about 3 months. And she said to me, if I had a family member, I would defer to their wishes. But she didn't have any family. She was supported by a small group of very, very close friends. And I saw her, as the coordinator of the program, the referral that she'd put in for MAID was misdirected for about 6 weeks. And I went to her to apologize for the misdirection. And I said, but in retrospect, were you glad to have had these last 6 weeks? And her answer, this was before the first election in the States. And she said, no, I would have had it sooner. I've been watching Donald Trump campaign. I'm glad to be spared the outcome. A very capable woman in her thinking. And I thought it was an interesting statement that she was sorry to have She wasn't angry that her referral was misdirected, but she describes her reasons for wanting MAID. Let me turn my volume up.
The options that are available don't fit me. I could have long-term palliative care where the end would be the same. I would die. I could have sedation and sleep. But the one thing that I so value about MAID is I can leave with my cognitive faculties. And that matters a great deal to me. Yes, there are. The last time my mother visited me in Toronto, I was a grad student. She would help me financially. I never
Howdy, everyone. Apparently our presenter's screen froze. We'll, there, she's back. All right. Sorry, Dr. Lee, not sure what happened. But if you would like to finish up, we'd really appreciate it. You're muted.
So sorry, my internet just cut out. I don't know what happened. I will come back and
sounds like a good life.
basically she just finishes by saying how many 82-year-olds had such a good life. And I was very close to the end anyway. What I wanted to emphasize with her or illustrate with her was that what mattered, she had good palliative care. She was not physically suffering. What mattered to her was to die cognitively intact. There was no way, nothing I could have done to give her that other than to give her MAID. Because she was a PhD, that everything about her life was dependent on her intellect, and it mattered so much to her. What was really interesting is that when the person who gave her MAID came out of the room after giving it to her, there were tears in his eyes and the nurse was crying. She had all her friends around her and he had the IV set up, her arm was out, and she was talking to her friends. And she turned to him and said, go, start, right? Because he wasn't going. And what she was doing was, in that moment, doing what she didn't do for her friends, for her mother. She was telling each of her friends how much she loved them, what they meant to her, what they had done for her. She died thanking her friends. And so the provider, who was an emergency room physician, came out with tears in his eyes, and his first words were, boy, when I go, that's how I want to go. And I would say that the interesting thing about MAID clinically for me is there's no other branch of medicine where I've seen such depth of emotion shared between healthcare providers. It's an incredibly poignant line of work. And there is something about MAID deaths that are different. All deaths, of course, are poignant and mostly sad. MAID deaths tend not to be, but it's such an opportunity for healthcare providers to share together, which is what I hope I've been able to share with you a little bit today. That was my last slide, except to show you the staff that represents the two snakes that are the merger of healing and curing. And I think in many ways, that's the way I've come to think of MAID, that even when you can't heal, you can still cure. Okay, I'm going to stop and hope my internet keeps working.
Thank you so much. Stephen, I'll let you moderate at this point.
Yes, wonderful. I'm sort of scrolling through to see if there were some questions in the chat. Yes. Also, people who have questions, you can just raise your hands through the virtual raising would be easier for me to see. Question, how does the literature on psychiatric futility account for comorbid substance use disorders?
It doesn't.
There we go.
It's yeah, it doesn't. That's the literature on psychiatric futility is very early, and its focus is more in schizophrenia, and maybe eating disorders. And it is, I think the challenge with it is by the time you've reached psychiatric futility, generally you wouldn't be capable. But of course, theoretically you could be, and it's all to be evaluated. And maybe you're not capable for psychiatric treatment, but you could be capable for MAID. I don't know because I've not seen a patient like this yet. I'll come back and tell you when I have the experience. If I have.
Thank you. Allison. You're muted.
My apologies. So first, thank you very much indeed for such a wonderful talk, very informative, and help to capture the the personal dimension of being a clinician in this area. Have there been, my question is, have there been any legal challenges, or if not legal challenges, then public discussion about mature minors in this respect? Requests from mature minors, or has that simply not arisen?
It's not arisen because it's not legal in Canada yet.
Right.
So Canada just passed parliamentary review where they recommended opening it to mature minors, but it hasn't happened yet. We have no test cases.
And there haven't been any cases those requests have been taken into the legal dimension.
Right.
Yeah. Okay, thank you.
Again, scrolling back, you had a statistic, 81% of requests result in MAID, 4% are ineligible. Does that mean 15% are people who requested, were eligible, but chose not to utilize it or died prior to utilizing it?
Yeah. And I think there's multiple reasons for that. It's not clear that we haven't been granular enough to capture qualitatively. I think we should capture why. And is it because their disease progressed too quickly and they lost capacity and died? I think that's a big chunk of them. Or is it because having the option was enough and they didn't need to go ahead with it? Or did they change their minds? And I could give you multiple clinical examples of patients who actually changed their minds and the pros and cons of that. But yes, to answer the question, is people who just didn't use it. The interesting thing is that it's only 15% in Canada that don't use their approvals. In Oregon, it's more like 40% of people are given the lethal prescription and don't fill it.
That's sort of a more specific question. Is there any what kinds of suffering is and isn't considered worthy of MAID? Suffering poverty within capitalism, especially for those living that reality, certainly is significant suffering, but where do we draw the line between applying MAID for a health diagnosis and applying it for health disparities, for example, that create disparate life experiences?
That's a great question to ask. I don't think I have the time to answer it. The way I would answer it, briefly, is I think it's a very valid point. I don't think we judge the types of suffering. It is more the intent of medicine in my mind. I don't struggle with assisted dying. If you're going to be dying, regardless of what I do, and you're unhappy with how you're going to die, I will assist you in that process. People who are wanting MAID for poverty and structural vulnerabilities aren't happy with how they're dying. Aren't distressed by how they're going to die. They're distressed by how they're living. And I'm no longer assisting a death. I'm assisting a suicide. And I think there's many things that can be done to help people with life suffering. Maybe should be one of those options for some people. How we define that, I don't know. But I personally ethically struggle a little more with assisting suicides than assisting deaths.
As a quick reminder, we are here at 1 o'clock and people may be leaving. Anyone requesting CME, please click the link that Dr. Offengendon put in the chat. Put your info in at that link. That's the best way to make sure you get your credit. And I apologize, I should have been letting you know who was asking these questions. I'll try to do that in better as I move forward. Stanley Truman asks about the current status of offering advanced directives for late stage dementia, especially in Quebec.
The current status is that it's like mature minors, not legal. But the legislative review has approved it to go forward, has said that we should go forward. So Canada will be looking to legislate that at some point. It will be allowed. I would say that, interestingly, most MAID practitioners feel uncomfortable with it, but I think the populace at large is in favor of it. And so we're just going to have to, it's the opposite of MAID for other indications where some public are not comfortable with it, but practitioners are. And it's all about needing to put yourself in there, right? If a patient has an advance directive and says, I want MAID under these circumstances, and then those circumstances occur and the practitioner enters a room and sees a perfectly happy person in front of them who isn't suffering, are you going to step in and act on their MAID request? I think it's a challenge. I think there's a way to do it. I'm personally in favor of it, but it's not allowed yet.
Jean Kerwin asks, can someone who's not facing a natural death use voluntary ceasing of eating and drinking to the point where they may have a foreseeable death? And I would actually expand that to a question that I also had, which is, yes, how does foreseeable death get understood when there is a treatment that perhaps is possible, but a patient refuses it?
Those are two separate questions and both great questions. Foreseeable natural death is the most challenging, I think most problematic criteria in our Canadian legislation because it's not defined. And there are certainly, I think there's so much variability, which is a safety issue. Some people do approve VSED, voluntarily stop eating and drinking, or VSPEC, voluntarily stopping preventive care, right? If you're quadriplegic and you're going to not be turned and allow a pressure sore. Some people would allow that. And so some people certainly did allow that under Bill C-14, where you needed to have a reasonably foreseeable natural death. Theoretically, we shouldn't have to use that anymore now that you don't need a reasonably foreseeable natural death. And there's debate practically in the country whether you would still allow someone who says they're going to stop eating and drinking to go on to the expedited path where you don't need to wait 10 days. So I think it's complex in Canada what to do with that, but it has been a route to MAID in Canada in the past. Around treatment refusal, you are allowed to refuse treatment. It's in the Canadian law. It is a very autonomy-based law. And so even if there's the potential for treatments that might work, this is why we're allowing going to allow MAID for mental disorders. There could still be effective treatments. It doesn't matter if you're capably declining them. But we have these clinical criteria where the assessor has to decide that this is a reasonable decision. So now we have a voice to say, you're not refusing it because you're too hopeless, that this is reasonable. You've tried enough. The problem is we don't have clear guidelines on what enough is.
Question, Roma Damanaskar. I'm wondering what you think about the role of public engagement in shaping MAID policy in Canada. Has the general public had sufficient opportunity to deliberate?
I think the general public has had a lot of opportunity to deliberate. Have they been consulted is a separate question. I think that the problem has been we have not had a really high quality and fulsome public attitude survey. As I said, in Canada, MAID did not come from pressure from the public. It was specific case law. And then there have been several public opinion polls, which are largely in favor of MAID in general. But then when you come down to specific circumstances for mental illness, for chronic disease, in general, people are in support of it. For palliative disease, the support drops for chronic disease, drops further for mental disease, but it also depends on how the question is asked and how the data are interpreted. So I don't think we have a clear sense of what the public wants. I also think that, I think as a clinician, I will do what the public wants. There was an earlier question I just thought flash up briefly about what to do for structural vulnerability suffering, where people really are suffering. I will do what the Canadian populace at large, because this is the country that trained me. I will do what they say, but I don't think we have a clear mandate from the public. What we have instead is a lot of media giving voice to people who have concerns about expansion. And I just don't know if the media is representing the majority of the populace or not. But there's a lot of pressure from the media to back off and slow down.
Christina Tetranu asks, would you be able to advise on how to start this conversation in a country where none of the assisted dying options are available?
You I think where you start is through lectures like the one I just gave you, where you try to give a balanced perspective, and you do the fundamental disagreements thing, where you lay out the values and what the issues are and show that there are some cases where there's actually benefit, where there, and I also think it's important to separate out what is medical versus what is society, what is cultural and what is legal. In many ways, I sometimes think MAID has been positioned in medicine so that we can safeguard it. But did it need to be? Right? There could be other frameworks in other countries. It doesn't have, if the country is going to say this is a right that patients have, suicide is not illegal. So why is assisting with suicide illegal? Countries could take this out of medicine and actually eliminate a layer of opposition. And I think it really comes back to doing good public attitude surveys and figuring out if you have a mandate.
If I have missed anyone's questions, please feel free to ask them now or rewrite them in the chat. I apologize if I missed one. Many congratulations to you in the chat for a lovely talk and discussion. I agree wholeheartedly.
Thank you very, very much.
Really my pleasure. I hope I did justice to the goals of this invited lecture.
Well, we are past time, so I appreciate greatly your taking time to give us your expertise on this. Thank you so very much. I agree with everybody on what a wonderful talk this is, and thank you all.